So after we understand the basics of diffusion images and understand what's the meaning of B value 0 and the DWI, which are the true sequences in our discussion, we'll come to the examples that we might encounter in our real life about what signals changes that we can see on these three sequences, the B0, W, and the generated ADC that we agreed upon that restricted diffusion will be shown up as dark signal and free diffusion will be shown up as a bright signal. Let's go to the first example of or scenario that we might encounter in our real practice. The first scenario is the commonest scenario, which is the scenario of true restricted diffusion. The B0 showed hyper-intense signal and the DWI showed hyper-intense signal. The hyper-intensity on DWI means either a true restricted diffusion or it means a T2 long relaxation or decay of the tissue. The ADC, it determines whether the region is due to restricted diffusion or due to T2 prolongation. Once the signal is shown as dark signal on ADC, then the conclusion is this lesion is represented as a restricted diffusion pathology, which is in this case resultant of an acute infarction. The second common scenario that we might see on our real practice is that scenario. Similar to the previous one, we are seeing B0 hyper-intense signal, and on WI we see hyper-intense signal, which also again have the possibilities of being restricted diffusion or due to T2 prolongation. But in this case, the ADC showed hyper-intense signal rather than dark signal, which means there is no restricted diffusion. There is rather free diffusion in this region. This case is represented as T2 shine through phenomena or pathology or explanation. And how we explain it? We explain it by being the region we are dealing with is having a T2 marked long relaxation or decay, which transmits or shines through the DWI and appears on ADC because the ADC is a result of generation and combination of the DWI and B0. The third scenario is less common scenario and it is consistent with artifact. When we say this is due to artifact rather than other pathology, when the DW image showed no abnormal signal and the B0 and the ADC showed a dark signal. Why this happens? As we remember, when we are generating the ADC and doing our DW images or sequences, we are dealing with ecoplanar study or sequence, which is highly susceptible for artifacts, and this is especially the susceptibility artifact, and this is what happens in this case. The fourth and last scenario that we might encounter is this scenario, which shows dark signal on the B0 and dark signal on the WI image. Dark signal on the DWI image means no restricted diffusion, as we know how we process our signal and deal with it with active and strong gradients. In the same time, it appears as intermediate signal on the ADC. This case is explained by having something called a markedly T2 short relaxation or decay lesion, and this is blackout T2 or reversed shine, and no restricted diffusion in this case is happening. These are four scenarios relatively common. The two first scenarios are very common. The second, third, and fourth scenarios are encountered in some cases and better to be familiar with their presentation and explanation. Now we will go to the part which is very important for practicing dealing with the DWI images and ADC. The clinical application of the DWI, which is nowadays becoming increasingly important, and to practice and to know and to applicate it really on the pathologists and our areas. Start with the neuroimaging, which is basically our talk and the most common used for this type of sequence. Neuroimaging in acute stroke and in brain abscess and brain tumors, we agreed that this is the case of true restricted diffusion. Acute stroke is based on permeability and cell swelling. Brain abscess and empyema is due to infection and high viscosity of the pathology, which makes the area markedly restricting molecular diffusion. The third one is brain tumors, which is characterized by markedly high cellularity and restricted diffusion at the same time. They noticed that some of the tumors, they can be mildly, moderately, or to a less degree positive as restricted diffusion and brightness on diffusion. But these tumors that I mentioned in my slide are almost always bright on diffusion images, which are CNS primary lymphoma, chordoma, malignant atypical meningioma, and colloid plexus tumor and pennant tumor. These tumors are almost always bright on diffusion images because of high cellularity. The other topic that is useful to use diffusion image in is diffuse axonal injury, where we find the microhemorrhages and microcortical injuries are bright on diffusion images, and also active multiple sclerosis lesions. They found that they share the presence of activity or brightness on diffusion images in the lesions that are active and take the contrast once we repeat the examination with contrast to rule out activity. And the other three last examples are helpful in differentiating lesions from others. That's to say, epidermoid cyst versus arachnoid cyst. Epidermoid cyst is bright on diffusion images compared to arachnoid cyst. Both are on T1 and T2 shared the hypo-intense and hyper-intense signal pattern. Diffusion will discriminate between the two. Cholesteatoma versus osteitis media. Cholesteatoma, they share location. It is an infective, slowly growing tumor process in the ear. To differentiate it from active inflammation, cholesteatoma is positive on diffusion images and otitis media is negative. Cytotoxic edema versus vasogenic edema. I will make little explanation about this pathology and because it is very important. Cytotoxic edema is the edema due to the cellular swelling. There is shift of the fluid from extracellular spaces to intracellular, which means the result of cellular swelling. Cellular swelling by default is the cause of restriction, and there will be restricted diffusion. The brain barrier is intact, and what is happening is mild intracellular swelling. Opposite to this finding is the vasogenic edema. Vasogenic edema is an edema which is seen in tumors, and it is explained by increased extracellular volume by shifting of fluid from intracellular to extracellular due to the damage and malfunctioning or irregularity of the blood-brain barrier. In this case, edema, fluid will accumulate an edema outside the cell, and it would show rather not restricted diffusion. It would show a signal of T2 prolongation and shining through the diffusion and come as bright on diffusion images and bright on ADC. That's what we see in our previous examination. It will be shown as the brightest, but the discriminative is the ADC. In cytotoxic edema, the ADC is hypointense. In vasogenic edema, the ADC is hyper-intense due to shining through. Another useful implication of DW images is in the spine images. I'll summarize them in infection, POTS disease, and other serious infections. They will become brightening on diffusion images. To exclude the collections around the spine, whether they are abscesses or seromas infection or collections. The other important category is the vertebral collapse, to differentiate between osteoporotic and malignant pathological collapses. Malignant is bright on diffusion, osteoporotic is not bright on diffusion. Also, internal organ imaging is very important in cases of metastasis and malignancy. Most of the cases, metastasis will show restricted diffusion, malignancy according to the cellularity, and also the follow-up once we see a lesion that is considered to be malignant due to metastasis or primary lesion, and there is diffusion restriction. We can follow the recovery of the lesion and progress according to the ADC values, and also the grading of benign versus malignant. Remember what we say, that benign lesions are approaching the value of low restricted diffusion near result of 1 multiplied by 10 to the power 3, which we said before. But malignant lesions are having lower values, so we can say that this lesion is malignant rather than benign when we are dealing with lesions or masses in the internal organs. This is a conclusive study about the clinical and technical application of diffusion images and ADC, and thank you for listening. Hopeful to see you again in another